Thank you, Rajiv and the ICH team for asking me to speak on this topic and for inviting me and forcing me to attend yesterday's session also and drilling genetics into my very primitive understanding of what genetics I had. I thank you especially for that. So, in the next few minutes, let us just see if we can quickly answer the following questions. We did have a cystic kidney disease symposium yesterday, so I had the opportunity to pick up what all was not discussed yesterday and only put those things here. So we are going to discuss about solitary renal cyst. So what do you do if you find an isolated single cyst in one of the kidneys? So how common it is? What all could be the possible etiology? Should we ignore it or should we act on it? And how to follow up these patients. So a simple solitary kidney cyst, as we all know, is quite common in adults. It can be an acquired cyst associated with normal aging. And the major problem or the major worry in our mind in such situations is to see whether it's going to be a benign cyst or a malignant cyst, whether it's going to be a renal cell carcinoma or something like that. But these concerns are not there in child. In a child, it's less common. It's a relatively rare finding. And it also, the worry is, could it be the first manifestation of a genetic problem? So that is our main worry. So the prevalence from ultrasound-based studies, which include somewhere between 15 to 20,000 children, there are two series at least which puts the prevalence between 0.2% to 1%. The inclusion criteria of these studies might be accountable for the slight difference in the prevalence. Some studies have not included patients with a known family history, while the more recent study, although it did include children with positive family history, this is the most study which included only children with single kidney cyst. And but they also ruled out or with known PKD, known syndromic associations were taken off from this study. So the prevalence of a solitary renal cyst in a non-syndromic or with family history but no known association of PKD would be somewhere around 1%. So how common again? It could be detected at any age. You could come across that it's even in the fetal period during an antenatal ultrasound or through the course of your childhood period due to any reason like abdominal pain or urinary tract infection or an incidental finding. Studies have shown that there is a slight female preponderance. The earlier studies showed a more female preponderance, but the current studies are showing a slight female preponderance only. And the most common indication was an abdominal pain or a urinary tract infection, and the third one being an antenatal ultrasound. An ultrasound being the most common modality which we are using for these abdominal pain and UTI, so that remains the most common modality by which you would find the initial cyst identification. So coming to the etiology, what all could it be if you find a solitary cyst? One is a hereditary cause, which we are all worried about and the most wanting to investigate further, is the finding of a polycystic kidney disease. So does it go on to have more cysts? That this child will have more cysts in the future when you follow them up. The most likely causes then could be your ADPKD, ARPKD, the broader spectrum of ciliopathies and some contiguous gene syndromes like tuberous sclerosis. And the non-hereditary causes, could it be part of a caput association and part of sporadic caput? And also, of course, these two conditions are non-hereditary because these two HLF1 beta associated kidney diseases and the syndromic larger group might not always present with cysts in subsequent generations. They could have a variety of caput-like presentations, and that's why I put it under non-hereditary. The other slightly lesser common things are calyceal diverticulum and parapelvic cysts could also present as a single solitary cyst, and the huge, again, but relatively lesser causes of acquired etiology like your trauma, infection, malignancy, and sometimes in children on long-term dialysis, you might find a couple of cysts in them. So just a little bit more about these uncommon, but definitely you could find them. Cystic dysplasia is part of caput or some defined genetic syndromes. You might find one or two cysts in there, and also the caput syndromes with or without obstructive uropathies. You might have some one or two cysts. The calyceal diverticulum is something like this, where I put a picture. Some of us might not have seen this. It's from an article. So there is an isthmus, and there is a calyx which is connected to the. It has an isthmus and connected to the pelvis. So if you do a further imaging, if you're interested in finding out what it is, it's a cyst or a diverticulum, you might want to do a CT urogram or an MR urogram and see whether it's filling in the excretory phase. Slightly, the calcium diverticulum, although solitary single renal cysts are more likely to be asymptomatic. Your calcium diverticulum can sometimes be symptomatic. So that's one differentiation. The other one is a parapelvic cyst. So these are the subset of cysts that can arise within the renal parenchyma and also adjacent to the renal size. They are incompletely surrounded by a renal parenchyma, sometimes like this, a very ectopic looking cyst towards one end, not completely surrounded. Again, the etiopathogenesis of the calcium diverticulum and the parapelvic cyst, whether they are congenital, whether they are acquired, nobody seems to know, and there is no clarity on that. So what happens, this is the most important thing that we'd all like to know, what happens to these solitary renal cysts? So in the larger series which was done between 2005 to 2011 and published in 2015, they saw a definitive diagnosis. They looked at 212 children, of which 89 of them had, of which they had at least 1 year follow-up in 89 patients. And the definitive diagnosis was achieved in only 18. They could find out a definitive diagnosis, so the yield was very little. What happened to these cysts? A majority of these cysts either resolved or decreased in size. And around almost 50% of them, the total burden or the size or the resolvation of the cyst was seen. The cyst remained stable in 30% and increased in size in 20% of the patients. And also the cyst to renal length ratio is something that they saw. It increased only in 16.9%. So only 20% of this whole cohort of single cyst actually progressed or increased in size. There's also this one series, I've not put many studies here due to want of time. There's also what happens to a single cyst that is identified antenatally. If you see postnatally, only almost 40% of them resolve completely, and in those who have not resolved, almost half of them were associated with some type of caput. So again, predominantly these solitary cysts do not have a very huge potential of becoming a genetic cystic kidney disorder or a polycystic kidney disease. So one of the important questions is whether it's a benign or a complex cyst. Like in adults, sometimes we have this confusion. So in this larger series of 212 patients, they saw that most of these cysts were simple, they were not complex, and only 3.8% had class 3, Bosnia grade 3 or 4 cysts. And even in those children, only when they attempted surgical resection, only one of them had a benign tumor of the kidney, which is a cystic nephroma. So predominantly malignancy is not our worry when we are looking at a simple single cyst. So could it be ADPKD is our other question. The most common cystic kidney disease that we all think is, could it be ADPKD? We all know in children, an ultrasound is what we most often use, and the Ravine criteria for diagnosing ADPKD, I put it up here. And almost, this should also be understood in the context of family history. Although we look for a positive family history in ADPKD, in 10 to 20% of patients, there might be a de novo mutation. So with that background, one of the studies that looked explicitly at the risk of ADPKD or the diagnosis of ADPKD in children with simple renal cyst, it looked at 84 patients with at least one renal cyst. Children with multiple cysts were also included in the study with at least 1 year follow-up. Complex cysts were excluded, but so it's a simple cyst. An ADPKD diagnosis is more likely when you have bilateral cysts, when you have multiple cysts, when you had a larger size of the single cyst, and an increased size on follow-up imaging. So these are the features that you would look in follow-up to. And also the size of the cyst remains a very good parameter. The size of the cyst is more than 25 millimeter on initial imaging. Almost all of them, almost 75% of them had ADPKD. So your ADPKD still remains a major diagnosis even if you find a single simple cyst. And when it's multiple cyst, it's almost always ADPKD when the size is also larger. So an algorithm for a simple kidney cyst would include an idea about whether it's a simple or a complex cyst, so take that out of the way immediately, and a family history of ADPKD. So now in India, just asking a family history would not be enough to go through this algorithm. A parental ultrasound would also be important, and keep in mind the Ravine criteria. The parents, most of our patients' parents might be younger. So they might be less than 40 years. So that again is a dilemma whether to take, whether they are positive or negative for a cystic kidney disease. So with that as background, and if the child is less than 15 years where you can't apply the Ravine criteria, so if there is a family history of ADPKD and you have found a cyst, most likely diagnosis could be an ADPKD in the background of a family history. And if the child is more than 15 years or there is more than 3 cysts in total in the ultrasound, again an ADPKD diagnosis can be entertained. With absence of all these features and the absence of other problems in the child, whether the child is symptomatic, whether the child has an hypertension or urinary analysis, or the rest of the kidney is normal, the echogenicity is normal, the rest of the structures are all normal, then we are just having an isolated simple cyst with no family history, with no progression, with none of the other problems in the kidney or in the symptoms, then you are just left to follow up these children with only an ultrasound. So that's all is necessary in these majority of these children. So how the frequency of follow-up, should we do them, should we have a very close follow-up or can we space out the follow-up? So there is some discordance between pediatric urologists and pediatric nephrologists. Urologists might want to see the children more frequently, once in 6 months. I think that's in the background of whether it's being a complex cyst or a simple cyst, whether any surgical intervention is needed. And pediatric nephrologists tend to think when you've ruled out all these causes, it's more likely that you would only follow them up once in 1 to 2 years or so. And with more progressive follow-up, you might realize that the cyst is not progressing. You might even want to space out the ultrasound evaluation. And you're more likely to increase the frequency of imaging if there is bilateral cyst or any problems in the kidney function. So would you consider a genetic test? I promise you this is the only slide on genetics. And this is only if you are considering in this group of patients, if there is no family history, so there is already an established ADPKD or a liver cyst in any of the family history, you still not go ahead and do a genetics. But if it's not there and there is a treatment available, or there is presence of non-renal anomalies, or you're interested in looking at what are the non-renal anomalies which could be sort of have an effect if you identify before, so you would still do a genetics only in this group. In the second group, again, it's a yes or no. You might want to do, if you're thinking about an HNF1 beta associated or a syndromic purposes. In sporadic caput, it's only for academic or research purposes that one would attempt to genetics. And in the majority of the third part, you would not probably want to do a genetics, you might not find anything. So in summary, a solitary renal cyst is relatively rare and often detected incidentally when imaging is done for another indication. ADPKD, cystic dysplasia associated with caput, remains the most common diagnosis among most of these children, and when detected antenatally, majority of them resolve, and those who persist also have a strong caput association. And malignant transformation is not a bother in children, and we do not really look into that too much. A family history, presence of large cyst, presence of multiple cysts or bilateral cysts in the future follow-up would indicate that more of them would have ADPKD, and genetics can only be useful in very carefully selected patients. Thank you.